Welcome to Dorsey and Whitney's webinar on final Stark and Anti-Kickback Statute rules, what you need to know. I'd like to introduce Alyssa Smith, a partner in Dorsey's Healthcare Transactions and Regulations Group. Alyssa?
Thank you, Rima. Hi, and good morning, everybody. We're very excited to be here today to talk about the most significant changes to the Stark and Anti-Kickback Statute in over a decade. As health lawyers, we spend a lot of our time advising our clients and helping them analyze their arrangements under these primary fraud and abuse laws. And so it's particularly fun for us to be able to think through and discuss how all of these changes are going to have a real impact on healthcare arrangements and on the healthcare industry. My name is Alyssa Smith, and I'm a partner and the co-chair of the Health Transactions and Regulations Practice Group here at Dorsey. I work regularly with providers and others in the healthcare industry to help structure their transactions and to help through policies and procedures to be in compliance with state and federal laws, and of course, importantly, the Stark and Anti-Kickback laws. With me today are my wonderful partners, Ross Emanuele and Laura Morgan. Ross is the co-chair of the firm's healthcare industry practice group, and he works in the provider, payer, and drug and device segments of the healthcare industry. His areas of expertise include the Stark and Anti-Kickback laws, as well as many other federal and state laws impacting those in the healthcare industry. Laura is also a Stark and anti-kickback expert, working closely with our healthcare clients to help them understand how these laws impact their business and how to navigate a wide range of arrangements and circumstances under these laws. We'll begin with a short agenda for today's program, starting with a brief background of the regulatory sprint initiative that has created the changed Stark and anti-kickback regulations that we're going to be exploring. Our program will include an in-depth discussion of what I think are the most significant changes, and those are the new value-based safe harbors and exceptions that will open the door for innovative arrangements in healthcare. Then we're going to explore the many clarifications and flexibilities in Stark and Anti-Kickback now, which are going to provide much needed certainty and reduce compliance burden in the long run. I also want to say at the outset that we're going to be covering a lot of material today, but we won't be able to address all of the changes in as much depth as we would like, just given our time constraints. So we prepared white papers for you on the final Stark and on the final anti-kickback rules that you will have received. These white papers go into a lot more detail, and we hope they'll be a helpful resource for you going forward. Okay, so we're going to start with a background on the regulatory sprint. As we all know, healthcare delivery and payment is in a transition period in our country. We're working to transition for payment and delivery of care based on volume to where payments based on the value of services and a payment system that rewards healthy outcomes for populations. For many years, stakeholders, including hospitals, physicians, and others, have pointed to healthcare fraud and abuse laws, such as Stark and Anti-Kickback in particular, as being a barrier and creating regulatory burden, so much so that they stop or prevent healthcare providers from collaborating around outcomes or quality-based arrangements. These laws are blamed for preventing innovation and being part of the cause to a broken healthcare system. So, in a bipartisan approach, stakeholders from across the industry asked for these outdated regulations to be modernized. They urged agencies in charge of existing regulations to remove barriers to these kinds of innovative initiatives and in particular to create ways that support value-based care models through these fraud and abuse laws. In August 2018, the Department of Health and Human Services launched a regulatory sprint to coordinated care in response to the stakeholder feedback. The agency started in August by publishing a request for information about ways that these laws could be modernized. Hundreds of comments were submitted. There are several laws that are a part of the regulatory sprint to coordinated care, but in this presentation, we're going to focus only on the Stark Law and the Anti-Kickback Statute, as well as just very briefly on the beneficiary inducement civil money penalty law, because these are the changes that were most recently finalized as part of the regulatory sprint. But it's important to know that just a few weeks ago, the Office for Civil Rights published proposed rules under HIPAA's privacy regulations, which are now in a comment period and we expect will be finalized as part of the regulatory sprint. Also, in 2020, Congress passed statutory changes to the substance abuse privacy laws with a mandate for final regulations under these Part 2 laws to be published in March of 2021. So stay tuned for both of those privacy laws, changes under both of those privacy laws. With respect to Stark, anti-kickback, and beneficiary inducement, on October 9 of 2019, the Department of Health and Human Services issued the proposed rules. COVID sidelined the finalization of the rules for several months, but on November 20th, 2020, CMS and OIG released the final rules and they were officially published in the Federal Register on December 2nd. They're slated to go into effect January 19, 2021, in just a couple of weeks, just one day before President-elect Biden's inauguration. Of note, there is a final rule that has an effective date that's later. That effective date will be next January 2022, and that's the rule that'll impact physician group practices, including hospital-owned physician group practices. This rule is has a later effective date because it's likely to have more significant changes on the current way that many physician groups structure compensation. Immediately after the final rules were published, we started to hear questions about whether the changes to Stark and anti-kickback would basically eliminate the Stark Law or the anti-kickback statute or make the laws less important. The answer to that is no. These laws are and will continue to be significant enforcement tools by the federal government to prevent fraud and abuse practices and healthcare programs. The penalties are the same, the enforcement mechanism is the same. In fact, I think probably at the outset, there's likely to be an increase in compliance activities associated with the laws as everyone is taking time to evaluate them and implement operational changes that they may want to implement in order to take advantage of some of the new flexibilities and new safe harbors and exceptions. There's a lot of positive change, though, in these laws that we're going to focus on today. They add flexibilities, and where CMS and OIG have recognized some of the more technical requirements aren't necessary to prevent fraud and abuse and have caused a lot of self-reporting. That's where CMS and OIG have either eliminated or softened some of the requirements to the technical rules. And we'll get into those today. But for now, I just wanted to mention that these changes do not mean that Stark and anti-kickback are going away or have been diminished. One other point is that at the same time that these final rules were published, OIG published some other pretty significant changes to the safe harbors that are not part of the regulatory sprint, but instead are related to drug payment and discounts. We're not going to include those changes in our presentation today, but I wanted to make you aware of them because they were published at the exact same time. They go into effect a couple of weeks after the regulatory sprint Stark and anti-kickback rules. But there has been a lot of questions about these other new safe harbors. This is a revision to the current discount safe harbor in the anti-kickback statute and two new safe harbors that were added, one for a point of sale reduction in the price of pharmaceutical products and one for PBM service fees. And again, all of those go into effect at the end of this month on January 29th. On this slide, I just provide a visual of the agencies that have been involved in the regulatory sprint. We have CMS, OIG, and then the Office for Civil Rights and the Substance Abuse and Mental Health Service Administration, with both OCR and SAMHSA being involved in the privacy regulations and modernizing those. Before we go into the proposed rules in detail, I want to give you a brief overview of these laws that we're going to be discussing today. I think it's important to do the overview to kind of help ground us as we're thinking through how these law changes are going to impact operations. The types of fraud and abuse these laws are intended to prevent from a policy perspective are also important to keep in mind as you're thinking through the changes. And those types of fraud and abuse are things like stinting on care or underutilization, cherry picking, and that's where the most valuable patients would be chosen to provide care to, lemon dropping, and that's denying care to undesirable patients, or any kind of manipulating or falsifying data in order to verify outcomes. While an overarching theme in the final rules is to reduce regulatory burdens to care coordination, the agencies have still been very careful to structure the new rules and rule changes to make sure that these protections against this kind of fraud and abuse still remains intact. All right, with that, let me just go over quickly with Stark, anti-kickback, and the beneficiary inducement law. The Stark Law applies to compensation or ownership arrangements with physicians. It's a strict liability law, meaning that intent does not matter for purposes of determining whether the law is violated. You either meet the requirements of Stark or you don't, meaning you violated the law. The Stark Law also has extremely significant financial penalties, including false claims liability. And for that reason, health lawyers typically begin their fraud and abuse analysis of any kind of arrangement with a Stark Law analysis. The Stark Law contains a referral prohibition and a billing prohibition. Under the referral prohibition, if a physician or their family has a financial relationship with an entity, such as a hospital, for example, the physician is not allowed to make referrals to the entity for any Medicare designated health services or DHS unless a Stark exception applies. There's also a billing prohibition, which says that you can't bill for the physician referrals of DHS. You can see we've underlined several terms on the slide. These terms are ones that we typically spend the most time analyzing when we're working with our clients. In particular, once we determine that Stark is implicated because we have a physician financial relationship, we need to look for an exception. Each exception has multiple elements, and it's important that all elements are met in order to comply with Stark. The final rules address much of the fundamental terminology of Stark and many elements of existing exceptions, and they also add some new exceptions. The anti-kickback statute is much broader than Stark in that anyone can violate the anti-kickback statute. It's not just limited to financial relationships with physicians, and any federal healthcare program, not just Medicare, is covered by the law, and any item or service is relevant, not just designated health services. The anti-kickback statute does not have such a prescriptive formula of what must be true about an arrangement in order to not violate the law. Instead, what the anti-kickback statute says is it's a crime to knowingly and willfully offer, pay, solicit, or receive remuneration in exchange for referrals or in exchange for the generation of federal healthcare program business. The government need only prove that one purpose of the remuneration is to induce, reward, solicit, or receive the referrals or the generation of federal healthcare program business. The anti-kickback statute includes safe harbors that protect certain arrangements from liability under the statute if they meet all the elements of the safe harbor. The safe harbors under the anti-kickback statute are similar to, but somewhat different from the Stark exceptions. Like our analysis under Stark, health lawyers spend much of our time in fraud and abuse analysis under anti-kickback, looking at whether arrangements meet the requirements of a safe harbor. While the parties have to meet every element of a safe harbor to have its protection, unlike Stark, you don't have to meet every element in order to not violate the law. Instead, if you don't meet every element of a safe harbor, the government would analyze the arrangement on its facts and circumstances. In other words, meeting a safe harbor is voluntary. The final rules we're going to talk about today add several new safe harbors to protect value-based arrangements, and they also make changes to existing safe harbors to add flexibilities for parties using common safe harbors to protect their arrangements. The OIG and CMS work together in promulgating these final rules. Many changes that we'll talk about today are similar, but there are some significant differences. between the Stark Law and the Anti-Kickback Statute changes, and here's why. The agencies view these rules as a pathway for parties entering into value-based arrangements that are subject to both laws to develop arrangements that can avoid the strict liability of Stark for technical noncompliance while still ensuring that the AKS or the Anti-Kickback Statute serves as a backstop that protects federal programs and beneficiaries against abusive relationships. In other words, while what you'll see many times is that the voluntary safe harbors are more difficult to meet, and this is intentional because this allows the federal government to still have the ability to pursue parties who are engaging in arrangements that are intentional kickback schemes. And finally, just briefly, there's a third law that has one change to it, and that's the beneficiary inducements civil money penalty law. This law is similar to the anti-kickback statute, which prohibits payments to generate federal healthcare program business, except this one is a little bit more narrow. It's focused only on Medicare and Medicaid beneficiaries and only on payments from healthcare providers that provide remuneration to those beneficiaries where the healthcare providers know or should know that the remuneration or the gift is likely to induce that patient to select a particular provider now or in the future. Similar to Stark and anti-kickback, the beneficiary inducement civil money penalty law includes many exceptions to its definition of what constitutes illegal remuneration. And one of the changes that we'll talk today is a new exception that adds some flexibility for providing telehealth technologies for patients receiving in-home dialysis. With that, I'm going to turn it over to Laura.
Great. Thank you, Alyssa. So turning to the first major theme of the final Stark and AKS rules is the value-based exceptions and safe harbors. So there's 3 new Stark exceptions and AKS safe harbors related to value-based arrangements that are similar to each other in many respects, and 3 additional AKS safe harbors that relate to value-based arrangements or use value-based concepts. So in understanding how these new exceptions and safe harbors and how your organization may be able to take advantage of them, the first step is to understand the new value-based terminology used in them, as this really formulates the compliance framework for organizations to meet the exceptions or safe harbors. And fortunately, as Alyssa mentioned, OIG and CMS worked really closely together in publishing these final rules. So these definitions are aligned in nearly all respects. So this terminology, lots of new defined terms. Bottom line, the new exceptions and safe harbors protect remuneration paid between or among a value-based enterprise, or VBE for short, and its VBE participants pursuant to a value-based arrangement reasonably designed to achieve at least one value-based purpose through performing value-based activities for a target patient population. So lots of new defined terms here. We're going to go into a little bit of detail on what each of them mean. First, starting out with a VBE, or value-based enterprise. I said these are 2 or more VBE participants, and I set forth here what they need to be doing. But I wanted to point out in particular that it needs to have an accountable body or person responsible for financial and operational oversight, and has to have a governing document describing the VBE and how its participants will achieve its value-based purposes, or intend to achieve its value-based purposes. And the value-based enterprise does not need to be a distinct legal entity, but it can be. And also, the governing document does not have to be formal bylaws. Even a written documentation memorializing the arrangement between the parties can serve as a required governing document, as long as it meets all the elements of describing the enterprise and its value-based purposes. So VBEs will probably take many forms. They're usually probably going to be networks of individuals or entities. Will probably range from highly complex legal entities to those that are more loosely affiliated. And it's possible that some of your existing arrangements may currently meet the definition of a VBE, or just small changes are needed to some of your existing arrangements to qualify as a VBE, and therefore be able to take advantage of these exceptions and safe harbors if the requirements of them are met. And of course, this is a great opportunity to consider whether you can pursue new opportunities that take advantage of the new exceptions and safe harbors.
So next, turning to a VBE participant. This is an individual or entity that engages in at least one value-based activity as part of a VBE. And I included some examples here of what type of entities this might be: hospital, physician group, physician, or some other entities. But importantly, the OIG in its final rules excluded a number of different types of entities from being eligible to rely on any of the value-based AKS safe harbors. And CMS did not include a similar ineligibility rule. So this is just with respect to the AKS safe harbors. And I listed here the number of the entities that are excluded from these AKS safe harbors. But importantly, these entities can participate in a VBE, but remuneration exchanged by them doesn't receive protection under the value-based safe harbors. And as Alyssa mentioned, compliance with the safe harbor is voluntary. It's evaluated on its facts and circumstances basis. So that doesn't mean that they cannot participate in the VBE. And some safe harbors do have a carve out to this general ineligibility rule for the exchange of digital health technology by certain entities. And the OIG set forth in preamble what entities with multiple lines of businesses should do to assess their predominant or core business to determine whether they may constitute one of these entities that are ineligible to take advantage of the safe harbors. And I included on this next slide a really helpful chart that was published on the OIG website. I won't go into it in detail, but I included it here as a reference for you. And we'll be covering each of these safe harbors in the coming slides. But this is a good resource for you to go back to see which safe harbor, which entities are and are not eligible for which safe harbor. And turning back to my helpful graphic here, the value-based arrangement. This is simply an arrangement for the provision of at least one value-based activity for a target patient population to which the only parties are the VBE or one or more of its participants, or VBE participants in the same VBE. And the term value-based activity is used here, and this simply means any of the following: the provision of an item or service, taking of an action, or refraining from taking an action, but does not include the making of a referral. Next, a value-based purpose. There are 4 separate value-based purposes, each as related to a target patient population, and I set forth what those are here. Well, one thing I wanted to pull out from the slide is that number 3, that there is a value-based purpose that of appropriately reducing costs to or growth in expenditures of payers without reducing quality of care. So this does not include reducing costs to providers or internal cost savings of a provider or supplier. However, that can be included in a value-based arrangement as long as there are other value-based purposes that are part of the arrangement. Next, the last term here is a target patient population. This is an identified patient population selected by the VBE or its participants based on legitimate verifiable criteria, have to be set out in writing in advance, and further the value-based purposes. And this could be a population with a certain diagnosis or that meets certain demographic criteria like age or geography. And as noted on the slide, while the selection criteria has to be set out in advance, the individual patients do not need to be identified in advance. So with that framework, I'll turn it over to Ross to get into the details of what the specific exceptions and safe harbors require.
Thank you. So I'm going to talk about 3 different sets of exceptions and safe harbors that apply to value-based arrangements. And they would protect or provide an exception or safe harbor protection for compensation among the value-based enterprise participants. Alyssa will then talk about a value-based arrangement safe harbor that deals with compensation to patients, and then some other couple other safe harbors that do not have to involve a value-based enterprise, but do involve value-based concepts. So the value-based arrangement safe harbors are really, there's 3 parallel sets of anti-kickback safe harbor and Stark exceptions that depend upon the degree of financial risk the taking. There's a financial risk exception in safe harbor, a less than full but meaningful or substantial downside financial risk exception in safe harbor, and then an exception in safe harbor where the parties are taking no financial risk. So let's talk first about the full financial risk, safe harbor, and exceptions. To meet these exceptions and safe harbors, the value-based enterprise has to assume complete financial responsibility for the total cost of all patient care items and services covered by a payer to patients in a target patient population. So you could pick a target patient population that only deals with a particular disease state. You could pick a target patient population that involved patients who receive their primary care services from physicians in your network. But once you pick that target patient population, the cost that you're responsible for includes every item or service that the applicable payer that you have the arrangement with covers for that target patient population. The safe harbor and exception would protect any payments among the value-based participants that involve managing the care of patients in that target patient population. The value-based enterprise would probably take things like a capitated payment or a global budget payment for the total cost of care from the payer, and then be able to share that payment with anyone in the value-based enterprise that's a participant in the value-based enterprise for managing or taking care of that target patient population. So it doesn't have to be fair market value, doesn't have to avoid relating to the volume or value of referrals, doesn't even have to be commercially reasonable. So really if you take a step back, in this circumstance, the full financial risk is being undertaken by this network of presumably providers from a payer. In other words, in some sense, the payer-provider distinction is going away in many respects. And this safe harbor and exception really recognize that once that occurs, the protection against overutilization or the other things that the Anti-Kickback Statute and the Stark Statute are trying to protect against really doesn't become an issue anymore. And so this safe harbor and exception would protect fully any arrangements between the enterprise participants once that full financial risk is taken. Probably most organizations, at least in the near term, are not going to be able to take advantage of this because of the degree of financial risk that is being undertaken. But it's a signal of what these safe harbors and exceptions are trying to lead us toward in terms of the healthcare system. An exception in safe harbor that may be more apt to be taken advantage of by most healthcare organizations is where you're not taking full financial risk, but there is some degree of risk, some meaningful or substantial degree of risk being taken. The Stark exception and anti-kickback safe harbor diverge in a very important respect in this sort of middle financial risk safe harbor and exception. The Stark exception does not require any risk to be taken from a payer. Okay, so there is only one level of risk that has to be taken. Remember that Stark is about relationships between a physician and an entity that bills for certain designated health services. And the only risk that has to be taken to meet the Stark exception is that the physician has to take substantial or meaningful downside risk from the value-based enterprise in order to achieve certain value-based purposes. Remember that value-based purposes cannot merely be cost savings of the value-based enterprise. So if, for instance, the physician is taking at least 10%, which is the threshold for meaningful in the Stark exception, 10% of the compensation under the arrangement is at risk for failing to achieve, say, quality care metrics, or certain process or outcomes measures, or other care coordination goals, that would fit within this exception. So it would allow you to provide withholds or repayments or incentive pay to the physician that is tied to meeting those goals. So if you had $100,000 in base pay, but $25,000 in additional payment was at risk for achieving certain value-based purpose metrics, that would meet this exception. Again, no relationship with a financial relationship in terms of risk with the payer has to be The kickback harbor for substantial downside risk is very different. There, two levels of risk have to occur. First, the value-based enterprise has to take substantial downside financial risk from a payer. And then the value-based enterprise participant has to share in a meaningful way, at least 5%, of that substantial downside financial risk that the value-based enterprise is taking. There's at least three ways that, well, there are three ways that you can take substantial downside financial risk. It's 30% or 20% from the payer, depending upon the methodology. I won't go into detail on that. But what you see here is, if you think about how this is likely to be applied, at least in the near term, it seems to me that it's most likely going to be applied, or most easily applied, to employed physicians. Because if you're not under arrangement where you're taking risk from a payer, there's no analogous anti-kickback safe harbor that you can take advantage of. However, if you're meeting a Stark exception, under this meaningful downside financial risk, and you have employed physicians, there you can take advantage of the employment safe harbor. So for employed physicians, you've got the anti-kickback safe harbor applying, and then on top of base pay with your employed physicians, you may be able to take advantage of the Stark exception if you're putting the physicians at meaningful financial risk for meeting certain quality of care metrics or other process or outcome metrics. You can pay them on top of that base pay. Again, fair market value is not relevant here. Volume or value of referrals is not relevant here. These are not elements of this exception. However, the payment has to be for the value-based activities that the physicians are undertaking. That, in some loose way, achieves the same purpose as a fair market value or commercially reasonable standard, because you couldn't use these types of payments to pay the physician for other referrals that are outside of the value-based arrangement. They do have to be for or result from the physician's activities under the value-based arrangement. If we move on to where the Stark exception and anti-kickback safe harbor, where no financial risk is being undertaken, these look very different on the Stark side and the anti-kickback side for a couple fundamental reasons. First, where no financial risk is being undertaken, the Stark exception allows both in-kind and monetary payments. On the anti-kickback side, as we'll see, only in-kind payments are allowed. But let's first talk about the no financial risk Stark exception. There can be in-kind or monetary payments made for value-based activities that physicians undertake if the arrangement is fully documented, meaning all the methodologies, all the value-based purposes, how you believe the value-based activities are going to help you achieve the value-based purposes, all that's in writing. The payment methodology has to be set in advance. Here, because no financial risk is undertaken, there is a commercially reasonable standard, and the remuneration has to be for or results from the value-based activities by the recipient for the target patient population. In a way, in a certain extent, this brings in some intent element into assessing whether you're meeting the exception or not, because there may be certain documents or communications that could potentially indicate that the payment under this, ostensibly under this exception, is for other arrangements outside of the target patient population or other referrals. And that would be a problem because you wouldn't be meeting this exception. This exception would apply to, let's say, just a physician, incentivizing physicians to meet certain care protocols or meeting certain process or outcome measures where there's no financial risk being undertaken by the physicians. You're just paying them for achieving these certain measures or outcomes. There has to be meaningful annual monitoring to meet this exception, which means at least annually, the value-based enterprise, someone who is in charge of the value-based enterprise, has to assess whether the value-based purposes are being met, whether the value-based activities are still effective in meeting the value-based purpose. If to do this monitoring, you fall outside of the exception. You can't meet the exception unless you do this monitoring at least annually. If you find that the measures are ineffective in meeting your purposes, you have to either terminate the arrangement or amend it, the types of activities you're incentivizing in order to believe that you are going to achieve your value-based purposes. But again, you have to do this monitoring. So, and remember, this is a Stark exception. So if you fail to do the monitoring, for example, every referral that the physicians that you're paying would not meet a Stark exception, and the referrals would be prohibited, even referrals that are outside of the value-based arrangement. On the anti-kickback side, where there's no financial risk being taken, the safe harbor only protects in-kind payment, and the recipients have to contribute at least 15% of the cost or fair market value. The in-kind payment has to be used predominantly for the value-based activities that are directly connected to coordination and management of care. So in-kind payment that is multifunctional, that is not used predominantly for the value-based activities, but that the recipients use substantially for other purposes, would not fall under the safe harbor, would not be protected. It has to be commercially reasonable, and it has to be fully documented. This might protect things such as hospitals providing care managers to physician group to help provide post-discharge follow-up to the group's patients, or certain equipment that might be used to alert physicians to needed interventions to prevent readmissions. Again, however, the recipients would have to pay 15% of the cost or the fair market value of those, of the cost or fair market value of that equipment. Laura alluded to the fact that certain types of entities, such as pharmaceutical manufacturers, medical device manufacturers, PBMs, labs, compound pharmacies, are not eligible to receive the protection of the safe harbors. And that's true with a couple exceptions. For instance, in this no financial risk safe harbor, certain entities, DME suppliers and medical device manufacturers, can provide limited technology that is used to capture, transmit, or aggregate or analyze data, and is used for care coordination. They can receive safe harbor protection, providing that sort of limited digital health technology to the recipients. Interestingly, however, the OIG said that if you're a medical device manufacturer who, through the CMS open payment system, has declared you have physician ownership, you are not allowed to even provide that limited digital health technology, or at least receive the safe harbor protection for providing that technology to the participants. With that, I'll send it over to Alyssa to talk about a safe harbor that deals with compensation of patients.
Okay, thanks, Ross. Another new safe harbor is one that protects the provision of patient engagement tools and support to a patient in a target patient population by a participant in a value-based enterprise. Many of the examples given by the OIG under this safe harbor are technology-based. An example is a smart pill bottle, which would help with adherence to a particular drug regimen. But items and services that address social determinants of health, like providing free childcare to help ensure a patient can attend their appointments, would also be covered by this new safe harbor. There are several detailed requirements that have to be met in order to qualify for the safe harbor. The tool has to be furnished directly to the patient or their caregiver by a VBE participant. So you can see this safe harbor still is using that same terminology, those new defined terms that Laura covered. There can be no outside funding or contribution to the tool or the support by any of the ineligible entities that Laura described. The value of the tool and support cannot exceed $500 annually, and there will be an increase for inflation over the years. The tool or support has to be in kind, so no cash or cash equivalent. A voucher would be okay, and OIG discussed limited use of gift cards in certain circumstances. The tool or support has to be recommended by the patient's provider. It must be preventative or health-related technology, patient monitoring tools and services or supports designed to identify and address a patient's social determinants of health, and it has to have a direct connection to coordination and management of care of the target patient population. The tool also has to advance one of a specific list of goals, for example, adherence or management of a disease. And there's a list of things the tool cannot do or limitations. First, the providers in the VBE cannot include any items or services used for patient recruitment or marketing. The tools cannot result in medically unnecessary or inappropriate items or services, and the tool or support can't be determined based on the insurance status of a patient. Another new safe harbor is one that protects payments between and among parties to a CMS sponsored arrangement. There are a number of CMS models available for payment. This new safe harbor will reduce the need for OIG to issue separate fraud and abuse waivers for any of the new CMS sponsored payment models that it publishes, and will provide, instead of those individual fraud and abuse waivers that go along with each model, it'll provide uniformity in having a safe harbor that will apply to all of the models. The safe harbor also permits remuneration in the form of patient incentives and supports to any patients that are covered under a CMS model if they're furnished consistent with the model by a model participant directly to a patient, and as long as certain requirements are met, such as the incentives are determined to advance goals of the CMS model. There's no parallel exception under Stark to cover the CMS sponsored models, and there's a reason for that. OIG talked about that, and that's because the third Stark value-based exception that Ross covered is broad enough in OIG's determination to encompass protection for participation in CMS sponsored models. Additionally, OIG is adding a second section to the personal services and management contract safe harbor. This is a safe harbor that may be familiar to all of you, and they've added a pretty lengthy second part to it that protects payments for outcomes, so payments based on outcomes, rather than the first part or the current part of the personal services and management contract safe harbor, which protects payments for services. The requirements for this new outcomes-based payment safe harbor are burdensome. I'm going to cover them just briefly here on the slide. Many of the requirements and the terminology might sound familiar to you, but they're not. OIG is not using the same defined terms. They certainly are drawing from value-based concepts, but this second part of the personal services and management contract safe harbor does not require the parties to be in a value-based enterprise and doesn't use the same terminology, which Laura has already defined, but it's going to sound really familiar. So some of the requirements are the payments have to be in the context of an arrangement in which the principal and agent are collaborating to do one or both of the following. One, measurably improve or maintain improvement in quality of patient care. Or two, appropriately and materially reduce payer costs or growth in payer expenditures while also improving or maintaining improved quality of patient care. The goals of the parties to the arrangement have to be based on benchmarks, and the outcomes goals themselves have to be supported by clinical evidence or credible medical support. And both the benchmarks and the clinical evidence for the benchmarks have to be documented in the agreement between the parties. Importantly, there's some restrictions on what types of outcomes can count for protection under the new safe harbor. Outcomes that relate solely to improving patient satisfaction or convenience do not count, although they could be part of a larger group of outcomes goals for the parties. They just can't be the sole outcome upon which the payment would be made under this safe harbor. Also, even more importantly, outcomes for solely achieving only internal cost savings of the principal are not covered. This is notable because this would be a typical gain sharing arrangement where savings that are achieved by the agent can help to share in some of those savings that they've made for the principal. That said, the prohibition only states that gain sharing or reducing costs for the principal can't be the sole outcome upon which payments are made. So just like the patient satisfaction and convenience outcomes, a gain sharing outcome could be part of a larger group of outcomes that parties would be working to achieve. Another requirement is that the parties have to regularly monitor and assess the agent's performance and then rebase those benchmarks to account for improvements. This means if the benchmarks have moved periodically, such as each year, that the parties have to reset the floor against which improvements are measured in order to be eligible for the outcomes payments. The final slide here on the outcomes-based payment safe harbor includes a lot of the detailed requirements that are covered under the slide. And I'm not going to go over all of them. Many of these might be familiar to you since they're common in a number of anti-kickback safe harbors, such as the requirement to have a written agreement with a term of at least a year. But there's some additional requirements that are unique to this safe harbor. For example, like I mentioned, those outcomes measures and clinical evidence have to be included in the agreement, as well as a schedule for the parties to monitor and assess those outcomes. Also, in order to address some of the policy concerns that OIG has about patient stinting, the safe harbor requires there can't be any limitation on medical decision making and no incentives to reduce or limit medically necessary services. And the principal has to have policies and procedures adopted and in place to promptly address or correct medical performance failures or deficiencies that would result in quality from the payment arrangement. All right, that brings us to the end of our value-based changes. And now I'm going to turn it over to Laura to talk about the second part of our presentation today, which covers clarifications and flexibilities. We're going to start with the clarifications and flexibilities under the Stark Law. Laura?
Thanks, Alyssa. So as Alyssa mentioned, this is the second major topic of the final rules under the regulatory sprint is clarifications and flexibilities. So these include clarifications of the fundamental Stark terminology and requirements, as well as defined terms, and some new exceptions, safe harbors, and special rules that allow flexibility for some non-abusive practices. And many of these clarifications and flexibilities address facilitating the transition to value-based care, but notably, many of them apply beyond financial arrangements related to care coordination initiatives. And in fact, many of them do apply beyond this. So are crucial for all stakeholders to understand whether or not you are pursuing care coordination initiatives, particularly for the Stark Law, which is what we'll address first before turning to the OIG's changes. And the Stark Law clarifications and flexibilities almost all reduce the burden of complying with the Stark Law in very helpful ways, but not all the changes reduce the burden. As Alyssa mentioned, one in particular related to group practice compensation is more strict than previous regulations and will necessitate changing compensation methodologies for some group practices. So I'll turn to this one first. So a physician practice generally has to meet the group practice definition under the Stark regulations in order to avail itself of the Stark Law's in-office ancillary services exception. And part of the definition of a group practice under Stark is that compensation can't vary with the volume or value of referrals, except if it meets a special rule under the group practice definition. And if it does meet that special rule, then it can indirectly vary with the volume or value of referrals. And CMS made an important change to this special rule regarding overall profits. And this overall profits rule provides that where a group's profits from DHS or designated health services can be pooled in a group of 5 or more physicians and distributed in a way that does not directly take into account the volume or value of referrals. And what CMS did in the final rules is to clarify through a change to the regulatory text that this has to be all the profits of the group or the 5+ physician pod. What this means is that there cannot be something called split pooling of DHS on a service by service basis among but rather all the profits of the entire group or the 5+ physician pod have to be aggregated before distribution. And to provide an example to make this a bit more concrete, take, for example, a 15 physician group practice that has 3 kinds of DHS, lab, imaging, and drugs. Previously, this group practice, like many other group practices, interpreted the group practice definition to permit having one pod of 5 or more physicians include the lab profits, one pod of 5 or more perhaps overlapping physicians include the imaging profits, and one pod of 5 or more perhaps overlapping physicians include the profits from drugs. Now, based on this regulatory change, all of the profits of the group or of one of those 5+ physician pods have to be aggregated before distribution. What this means for this group in the example is that this 15 physician group has 3 pods of 5. If they have 3 pods of 5, all the DHS of each pod has to be aggregated before distribution. So that means that each pod will likely have more than one type of DHS within it. It can't be a service by service specific distribution. And CMS did say that different distribution methodologies for different pods are okay. But with respect to how that's aggregated, it has to be all the DHS of the group or the 5+ physician pod. And this is going to necessitate changes to compensation methodologies for many group practices, which have interpreted the overall profits rule previously as permitting split pooling of DHS. And while CMS clarified that this is actually a codification of their existing policy, they also recognize that there's been some confusion by stakeholders on this point. So they are not making this change effective until next January 1st to allow groups time to be able to review and amend their compensation methodologies as necessary in order to comply with this regulatory change. And the last point on this slide is a helpful point, which is also not effective until next January, is that profits from DHS that are directly attributable to a physician's participation in a VBE can be distributed directly to the participating physician. So those do not have to be aggregated before distribution. They can go directly to the physician, whether or not the physician's participation in that VBE has to do with the group practice. Next, turning to another major category of clarifications in the final Stark rules is with respect to the Stark big 3, quote unquote. So what the big 3 are, as I'm sure you are all aware, many Stark law exceptions require meeting these 3 fundamental requirements of commercially reasonable, compensation fair market value, and that the compensation paid under the arrangement is not determined in a manner that takes into account the volume or value of referrals, and in some cases, other business generated between the parties. So CMS finalized what it believes are some bright line objective regulations for these fundamental requirements in an effort to reduce some of the burden of complying with the Stark law. And CMS also reiterated that these fundamental requirements are separate and distinct from one another. So when each is included in a Stark exception, they each have to be individually satisfied. This is helpful, particularly with respect to fair market value and the take into account volume value of referral standard, which sometimes have been conflated in the Stark regulations. And lastly, the OIG did not add definitions similar to what CMS added, which would have been applicable to safe harbors that use similar terms like the personal services and management contract safe harbor. So these only apply for purposes of the Stark law. So now turning to the first of the big 3, commercially reasonable. CMS added a brand new definition of this term, which has not been defined by regulation before. So the new definition provides that the particular arrangement furthers a legitimate business purpose of the parties and is sensible considering the characteristics of the parties and their size, type, scope, and specialty. Basically, what CMS says that this means, the key question is that the arrangement has to make sense as a means to accomplish the parties' goals. And the second point of the commercially reasonable definition, which is codified in regulation text, is that an arrangement may be commercially reasonable even if it does not result in profit for one or more of the parties. And this is a very helpful clarification because there's been a lot of uncertainty on this point by stakeholders. So it's now based on this codification, it's now clear that parties can enter into an arrangement for other legitimate reasons other than profit, of which there can be many: community need, fulfillment of charity care obligations, and licensure obligations. But CMS did state that it's not convinced that the profitability of an arrangement is completely irrelevant. It still could go to whether or not the arrangement is in fact commercially reasonable, but it could be commercially reasonable even if it doesn't result in profit. The second of the big three is fair market value. And this is mostly just a clarifying edits by CMS to the definition of this term in the regulations. There's now separate definitions of fair market value for general application, of rental of equipment, and rental of office space, and a revised definition of general market value that's incorporated into each of the foregoing. And this is mostly just a reorganization of the terms, and a lot of the terminology used in the definition will be familiar, including the key components of needing to be an arm's length transaction with bona fide bargaining between the parties. And a couple of points I wanted to pull out from the CMS preamble text on the fair market value definition changes are that salary surveys are just a starting point for the determination of fair market value. CMS said it's not necessary to have a valuation or consult a salary survey, but if you do, that's just a starting point. You still have to look at the particular parties to the particular transaction. And in some cases, compensation or rental charges may be above or below what that salary survey or valuation shows, depending on the particular parties and the particular transaction. Lastly, CMS mentioned that there is not a prescribed valuation methodology, which is something they have stated before, and they reiterated. So this means that any commercially reasonable valuation methodology could be used. Lastly, turning to the third of the big three is the volume value standard. So CMS added new special rules that describe compensation that does take into account the volume or value of referrals or other business generated. So other than in the circumstances set forth in these special rules, compensation does not implicate these standards. So these special rules define the universe of the circumstances under which compensation is considered to implicate these standards. And they apply in all instances where that volume value standard appears in the Stark regulations, except for a couple of carve-outs specified in the special rule. So there's two different components of the volume value standard special rule. First is compensation from an entity to a physician, and on the next slide is compensation from a physician to an entity. So first, compensation from an entity to a physician, and I should point out here, this pulls some real mathematical formulas. CMS used some terms from algebra, so you have to brush off your 7th grade algebra skills to try to really provide some bright line rules here. So compensation from an entity to a physician or immediate family member takes into account the volume or value of referrals only if the formula used to calculate the compensation includes the physician's referrals to the entity as a variable, resulting in an increase or decrease in the comp that positively correlates with the number or value of the referrals. And there's a parallel rule for other business generated that reads almost exactly like this rule for referrals. And a positive correlation means that when one variable decreases, the other decreases, or one increases as the other increases. So an example I include here is where an entity is paying compensation to a physician, or it could be to an immediate family member. And the formula is 50% of collections from personally performed services, 50% of collections from referred DHS, and 50% of collections from non-DHS referrals. And this is a pretty obvious example of this would implicate the special rule mathematical formula, because here, when one variable increases, the other variable increases. And one of those variables includes the collections from referred DHS, so this would implicate the standard. Continuing on to the next slide, the second component of the special rule for the volume value standard is when compensation is from a physician or immediate family member to an entity, and it's basically the reverse of the other rule. That takes into account the volume or value of referrals only if the formula used to calculate the compensation includes the physician's referrals to the entity as a variable, resulting in an increase or decrease in the compensation that negatively correlates with the number or value of the referrals. And again, there's a parallel rule here for the other business generated standard. And a negative correlation from a 7th grade algebra is when one variable increases as the other decreases, or when one decreases as the other increases. So an example I included here is what's an example that CMS has in the preambles, when a physician leases medical office space from a hospital and the monthly rental charges are $5,000 per month, but are reduced by $5 for each test ordered by the physician and furnished in one of the hospital's outpatient departments. So expressing this in a formula, as I did on the slide, the monthly rental charges paid by the physician to the hospital are $5,000 minus $5 times the number of DHS referrals. And again, it's a pretty obvious example you can see here. When one variable increases, the other decreases. So the physician pays less rent to the hospital, the more referrals that he or she makes to the hospital. And this would clearly implicate the volume or value standard here. So stepping back a little bit from the regulation text on these new volume value special rules, it's, I think, to be determined whether these formulas really establish the bright line objective test that CMS sought to establish. I think there are still going to be some gray areas that are do not clearly fall inside or outside of those special rules, including an example of a litigated matter that many of you have heard of from the Halifax case. There was a threshold that the physicians, the profitability of a particular hospital department had to meet in order for the physicians to be eligible for a bonus pool. And the bonus pools, the actual compensation that went to the physician, did not necessarily vary with take into account the volume or value of referrals, but the eligibility for the bonus pool may have. So there, it's just really not clear whether this would set up that mathematical formula that would clearly implicate these standards. And I think there's going to be perhaps future rulemaking from CMS, perhaps some Stark advisory opinions that may be sought on this matter. And as a side note on that, CMS did a year ago revise the Stark advisory opinion regulations to make that process more accessible and straightforward for parties seeking clarification on their arrangements and whether they implicate Stark. And so this, I think, is going to be, there's going to be some time to kind of figure out whether or not these do really provide those bright line objective tests. A couple of points on related matters in the regulations with respect to the volume value standard. CMS pointed out that even though the group practice definition, which I covered earlier, it has a volume value language that's a bit different from other exceptions, but these special rules still apply to determining whether the volume value standard of the group practice definition is met. And even though the other changes to the group practice definition don't go into effect until next year, this would be applicable immediately when the final rules on the 19th go into effect, because it has to do with interpretation of that volume value special rule. Next, CMS made some changes to the unit-based rules, the special rules regarding unit-based compensation. So these special rules are essentially superseded by the special rules that CMS created on the volume value standard. But CMS left the unit-based rules in the regulations to assist parties, CMS, law enforcement, in applying historical policies in effect prior to the final rules. But CMS made it very clear that if compensation meets the volume value special rule, then the unit-based compensation can't be then used to deem it not to take into account the volume or value of referrals because that special rule defines the universe of when compensation does take into account the volume or value of referrals. Next, on indirect compensation, based on changes to the volume value standard, or the new special rule regarding the volume value standard, as well as some significant changes that CMS made to the indirect compensation definition, there will now be fewer arrangements that create an unbroken chain of financial relationships that would constitute an indirect compensation arrangement in the first place. So this is pretty notable that this really will change that indirect compensation analysis going forward. And lastly, on the directed referral special rule, as many of you may be familiar, particularly with respect to perhaps your employment agreements with physicians, the Stark regulations have a special rule for directed referrals that provides that a physician's compensation under an employment arrangement, personal services agreement, managed care contract can be conditioned on the physician's referrals to a particular provider, practitioner, or supplier if a number of specified requirements are met. And this includes, there's a set and advance standard, fair market value standard, not take into account the volume or value of referrals, meet an existing exception. And as you're probably familiar, there's also that carve out to the requirement for patient preference, insurance determination, or physician's professional medical judgment. So CMS made some pretty substantial changes to the directed referral special rule, and also added as a requirement to various Stark exceptions that if compensation is conditioned on referrals to a particular provider, practitioner, or supplier, the arrangement must meet the conditions of this special rule. And in the special rule, they removed the requirement that the compensation not take into account the volume or value of referrals, because CMS wanted to make it clear that the special volume value rule defines the universe of when compensation takes into account the volume or value of referrals. And they said that they no longer believe that compensation predicated on a physician making referrals to that particular provider, practitioner, or supplier should be evaluated for compliance with the volume or value standard, because that's really that mathematical formula. So now payment predicated on these referrals to a particular entity has to be evaluated for compliance with a special rule for directed referrals, which is already familiar in existing arrangements. So there's both a requirement in the existing Stark exceptions, as I mentioned, to comply with a special rule where it's implicated, which has not previously existed in those exceptions. And there's revisions to the special rule. They removed that take into account standard, but added a revision to specify that neither the existence of the compensation arrangement or the amount of compensation may be contingent on the number or value of referrals, but it may require an established percentage or ratio of referrals to a particular provider, practitioner, or supplier where requirements of the special rule are met. So it was this revision was, on the first part of this revision, is made to address a risk of program or patient abuse if a physician would receive no future compensation if for failing to refer as required, or if the amount of the physician's compensation was tied to referrals to the particular provider, practitioner, or supplier. But again, as I noted here, you can still do that a percentage or ratio of referrals to a particular provider, practitioner, or supplier, which is a helpful clarification. So with that, I'll turn it over to Ross to address some important changes in the Stark technical requirements and a new exception for limited remuneration.
We typically think of Stark as requiring precision in a number of ways to avoid the possibility of technical violations. So we think of Stark as requiring precision in terms of needing a contract before an arrangement begins, and precision in terms of implementing an arrangement. Once you have an arrangement, if you've agreed to pay physicians X, you need to continue to pay them X and not X plus 10%. Or if you are leasing space or providing services, you've defined the space that you're leasing. You have to implement it with precision and not add space without going back and changing your writing. There are a number of Stark provisions in the new rules that change that in significant ways, and the combination of them should allow parties to avoid technical Stark violations, or even seriously consider whether you have a technical Stark violations in many respects. Not in all respects, but in many. And I will give one caveat or big warning about this as well. But let me talk about what those are. There are really three of them. First, there is a writing. You think about the writing requirement in Stark, that all arrangements have to be in writing and signed prior to the beginning of the arrangement. And there are two sub-points to that. One is the clarification of what set in advance compensation means, and also some changes in how arrangements can be modified. So you have the writing standard. There's a grace period for writing. There's also a reconciliation, allowing parties to reconcile arrangements, meaning correct errors that you've made during arrangements, and to a certain limited time period after arrangements have terminated. And then on top of that, we have a new exception for limited remuneration to a physician, which almost serves as a de minimis exception that can be applied when errors are made and you can't find any other way to protect an arrangement. So let's start with the writing. Typically, Stark requires, again, that arrangements, financial arrangements with physicians be set out in writing. There was a grace period a few years ago set out for the signatures on an arrangement. So you could have an arrangement in writing, but if your only element that makes you fall outside of a Stark exception, say under a professional services arrangement, was that you hadn't gotten a signature, you could get the signature after the fact. These new rules allow you to get not only signature, but the writing itself after the fact. The rules also state, I should say, or clarify that any collection of documents, anytime there's a writing requirement, any collection of documents, including contemporaneous documents that evidence what the arrangement is, can constitute a writing. But even with that, there is a grace period for getting a writing to begin with. So any new arrangement, there is added flexibility to have a writing within 90 days of the start of the arrangement. So you don't have to have the writing the first date that services are provided or the first date that payment is made. You can have up to 90 days to get that writing into place. The arrangement has to meet all of the other requirements except the writing and signature requirements, including the requirement that compensation be set in advance, which begs the question, well, if you don't have a writing, how could our compensation methodology have been set in advance? And on that point, CMS says that set in advance compensation methodology not have to be writing. They have a provision in a regulation that deems it to be set in advance if the compensation methodology is in writing, but it's not the only way that you can set compensation in advance. So it could be by an email, it could be a conversation, it could be past practice. It could be that we've always paid, in the past, our practice has been to pay physicians for this type of service at this rate, and that's what we did in this case. So there may not be anything, any documentation at all involving this particular physician, but you could look to what you've paid past physicians for similar service and possibly say that that past practice with regard to other physicians has set the compensation for this particular physician in advance. Or if you've paid that particular physician for similar services under a particular methodology, and the services have changed somewhat, but you apply that same methodology, it's possible that that past practice for that particular physician has set in advance the compensation for the newer services. So you have a grace period of up to 90 days to get both the writing and signature on any new arrangement with physicians. On the next slide, there's also an important change to an issue that has been a complication in Stark for a long time, which is, when can we modify arrangements? Can we modify arrangements in the first year? What if we modify the arrangement within the first year, but then 10 months later, after that first modification, we want to modify it again? Can we do that? CMS has done away with all of that and essentially said that you are allowed to modify an arrangement at any time and an unlimited number of times, even during the first year. However, that 90-day grace period that I talked about a minute ago that applies to new arrangements does not apply to modifications to an existing arrangement. There is no 90-day grace period to document modifications to an existing arrangement. So you can modify an arrangement as many times as you want at any time during the arrangement, as long as you continue to meet all of the elements of the safe harbor. And typically we're talking about the personal services safe harbor here. So compensation still has to be sent in advance, not relate to volume or value referrals, and so forth. But you can modify at any time. But contrast to the grace period for new arrangements, any modification has to be in writing before the modification takes place, or you will not continue to meet the Stark exception. So that's an important warning to anyone who might take these changes as really allowing organizations to cut back on the discipline of documenting arrangements with physicians. I think that discipline is still important because of the need to document modifications before the modifications are made. I think it would be really hard to practically implement a policy within an organization that says, don't worry so much about getting new arrangements in writing before they start, but if you want to modify an arrangement, we have to make sure we put that in writing before the modification occurs. That distinction may be hard to practically implement. So I think it's important for organizations to continue to press on that discipline of putting contracts in place and written arrangements in place for all arrangements. But at the end of the day, if you found that you've tripped up on getting new arrangements in writing, the rules do provide a lot of flexibility to allow, in many circumstances, for you to find that you have not had a technical violation of Stark because of that. Moving on to reconciliation. The other thing that Stark, the CMS said, was that within a live arrangements or up to 90 days after termination of an arrangement, you can correct payment errors that you've made. This happens all the time. Simply errors are made. Instead of paying a physician X dollars for whatever reason, you started off or at some point changed it to pay them X plus whatever. Maybe there was a inflation adjuster required in a lease and it just was never implemented. The new rules allow you, within the time period that an arrangement is live, for you to fix any of those and not have violation, or you can fix them within 90 days after termination if they're identified and you don't have a Stark problem. If after the 90 days after termination has expired, then you would still have to deal with the potential for there to be a Stark violation, but not within the time that an arrangement is live or the 90 days post period. On top of that, on the next slide, you will see a new Stark exception, which is really like I said, sort of a de minimis exception. Essentially, you can pay a physician up to $5,000 per year, which will be adjusted for inflation, as long as it's fair market value for whatever the physician was providing, doesn't take into account the value of referrals. In other words, there's no indication that there's no fraud and abuse occurring. It was just an error. You don't have to have a signed agreement. Compensation does not have to be set in advance. So this can be, for any error, up to $5,000 per year for you can look to this exception to find that you don't have a Stark violation. These three elements can really be stacked on each other in some circumstances to find that you don't have a Stark problem. So you may have an arrangement that you started with a physician that was not documented. You learned about that late, may even be past the 90 days. You have the grace period. And then what happens after that 90 days, you may find was under $5,000. And so you can stack this exception on top of that to correct the error up to that amount. And then you may also go back and find that because any contemporaneous documentation of the arrangement can be a writing, you may find that you had a writing in the first place, even though you didn't have a contract. So these three elements, along with the set in advance and modification rules, really do allow, in many circumstances, organizations to find that there is not a technical Stark violation, where in the past you might have had an overpayment or even a self-disclosure to CMS to deal with it.
Okay, thank you, Ross and Laura, for covering the Stark specific changes. Very important topics for sure. Now we're going to switch gears slightly and cover new clarifications and flexibilities added under the Anti-Kickback Statute and one added under the Beneficiary Inducement Civil Money Penalty Law. First, the OIG added a new safe harbor, which essentially codifies the Accountable Care Organization Beneficiary Incentive Program exception, where a two-sided ACO or accountable care organization can provide patient incentive payments to assigned beneficiaries who receive primary care. Of note, this will probably be of limited help to expand what's already allowed because it's already permitted under the statutory law, but it's helpful to have the law codified in the safe harbor regulation so you can look at one place for the permitted activities. The OIG also made a change to the current free transportation safe harbor, and I know there was a question in the chat box about this earlier. There is a safe harbor under the Anti-Kickback Statute, which allows entities like hospitals, which was what was asked about, to provide free transportation to patients, except the safe harbor has a number of requirements, including restricting the mileage limits. What OIG did in these changes was to expand the mileage limits in response to comments it received. Specifically, OIG will now allow unlimited mileage for free to transport inpatients back home following discharge. Also, OIG expanded for rural areas the mileage limit that would be considered local from 50 miles to 75 miles to provide that free transportation for patients in rural areas. And then finally, the OIG clarified that ride sharing is going to be permissible and protected under the free transportation safe harbor. Additionally, the OIG made changes to the current personal services and management contract safe harbor to add some flexibilities. Earlier, I talked about a part 2 that was added to this existing safe harbor to protect outcomes-based payments, but OIG also made changes to the first part, which has already been in existence. The OIG made these changes, which are going to be very welcome changes, to align this safe harbor more closely with the Stark exception, which protects personal service arrangements. Currently, the safe harbor under the anti-kickback statute only protects arrangements that set out total compensation. Very common arrangements that are an hourly based arrangement are not protected under the safe harbor because, like they are under Stark, because the anti-kickback safe harbor requires the total aggregate to be set in advance, and there would be no way to know that for an hourly based arrangement. So now that the safe harbor has removed the word aggregate from the requirements, and only the methodology has to be set out in advance. Additionally, the current safe harbor does not protect part-time arrangements unless the exact schedule is included in the agreement. Many times parties won't know the exact schedule for part-time arrangements in advance, or the schedule could change over time, meaning that parties wouldn't have the certainty of the protection of the safe harbor. But OIG, in recognition that the risk from fraud and abuse is low, has removed the requirement for, if there's part-time services, the agreement to specify the exact intervals and precise length and exact charge for the intervals. So the change will now allow very common part-time professional service arrangements to have the protection of the safe harbor, which helps to eliminate uncertainty. The OIG has added changes to the warranties safe harbor as well. The current safe harbor only applies to a manufacturer or supplier's warranty for a single item and not to bundled items or to services that the manufacturer or supplier may want to offer. The OIG is now expanding the protection under the warranty safe harbor to protect a manufacturer or supplier's warranty for a bundle of items or for a bundle of items and related services, as long as federally reimbursable items and services subject to the warranty are reimbursed by the same federal healthcare program and in the same federal healthcare payment. So the reimbursement can't be split between payers or payments. The manufacturer supplier cannot condition a warranty on a buyer's exclusive use or on a minimum purchase of the manufacturer's items or services. And then the OIG added a new exception under a different law, which is the beneficiary inducement civil money penalty law, to allow for providers of dialysis or renal dialysis facilities to provide free telehealth technologies to patients who have end-stage renal disease, where their services are being paid for under Medicare Part B. There are some requirements. The patient has to be a current patient of the provider or that dialysis facility, or they have to have contacted the provider or the facility, and that's to prevent steering of patients to a particular provider. Also, the technologies that are going to be offered for facilitating that in-home dialysis can't be advertised or part of any solicitation for patients. And finally, they have to be given to patients for the purposes of furnishing telehealth services related to the patient's end-stage renal disease. All right, now I'm going to turn it over to Ross to finish our presentation by talking about some of the changes to technology-related exceptions and safe harbors.
Thank you. I'll do this very, very briefly, so hopefully we can get one or two questions in before time is up. I will skip talking about changes to the electronic health records donation exception. There were some changes to that, including that it can now apply to replacement technology, even technology that a physician or physician group already had, if they already had an EHR software system. But I really want to spend just a minute talking about a new exception in safe harbor that applies to donation of cybersecurity technology. As long as a donation of either hardware, software, training, other cybersecurity technology and services is predominantly used for cybersecurity purposes and does not directly take into account the volume or value of referrals by the physician group, or is set up as a condition of doing business with the particular donating entity, this exception in safe harbor allows entities to donate cybersecurity technology. It would include hardware, software, and services, as I mentioned, and is really broad. It is very rare to find both a Stark exception and a safe harbor with as few conditions as is placed on this. And I think this is a recognition of how the policy goal of having cybersecurity technology distributed really overrides to some degree the fraud and abuse concerns of these agencies. Because again, as long as it is predominantly used for cyber. So software or technologies may be suspect here if there is a substantial use beyond cybersecurity. As long as it's focused on cybersecurity, not set up as a condition of doing business and not directly related to referrals, that's all you have to meet the safe harbor and exception. And you can donate things like text and email traffic filtering technology to allow that kind of communication, say between a nursing home and a physician group or hospital and physician group, or other types of things that can be donated and have protections of the anti-kickback statute and exception from Stark.
All right, well, thank you. We have several questions, and I'm going to cover the first one is about transportation. Earlier, there was a question about the changes to the safe harbor for free transportation. I covered those changes, and they're helpful changes to expand the distance. Somebody asked, is the 75 miles one way or round trip? It is one way. The statute says the distance can be up to 75 miles between where you're taking the patient and the provider or supplier along the route. Let's see. Somebody asked if we could elaborate on the correcting overpayments to a physician during a term of the contract or 90 days after its termination. An example, oh, it wasn't finished. So yeah, the question wasn't finished. So, if an example, for instance. So Ross, I think you covered this one, the overpayment correction. Could you elaborate on that a bit?
Sure. Yeah. So a paradigm would just be simply an error. Suppose you had an arrangement with a group of physicians under which you were going to pay them, X dollars per month or week for a certain service, and it turns out that for whatever reason you ended up paying them X plus 20% starting in a particular time, or maybe the arrangement just started off wrong. And however it happened, the folks who send out the payment thought it was X dollars, or maybe a zero was left off of an email that communicated what the payment was to be. You can think of dozens of examples. As long as that is caught during an arrangement or up to 90 days later, you can reconcile the payment to what the arrangement was supposed to be, and you don't have a Stark issue. Whereas before, you at least, if that circumstance occurred, the organization would at least have to analyze it closely and consider whether there was a violation of Stark simply because of an error.
All right, we have one other question from the audience that I can see. Oh, and I think we got another one. This question is, how do the value-based exceptions, and the question came in, Ross, when you were talking about the middle risk exception, how do the value-based exceptions impact companies' clinical trials agreements with principal investigator physicians?
I'm not aware of how that would change much in the context of clinical trial agreements. Really, what the value-based, first of all, to have them apply at all, you'd have to have the sponsor of the clinical trial and the physicians who are part of the principal investigator network create a value-based enterprise, and that would have to be directed toward particular value-based purposes, as Laura pointed out in her part of the presentation. So that would be things like quality of care, care coordination, or reduction of cost to a payer, or moving from a volume to a value-based healthcare system. Those are typically not the type of things that clinical trial agreements are directed toward, or part of the purpose of clinical trial agreements. I'm not saying it's impossible, but I just don't really see that. Typically, clinical trial agreements are directed at ensuring that the trial is conducted and the data is provided to the sponsor of the trial for whatever their purposes are, an investigational product or so forth. So I think it's unlikely that they would have much impact on clinical trial arrangements. So that's my first thought about it.
Okay, thank you. We're over on time, so I think we'll wrap up here just to be respectful of everybody's time, but please feel free to reach out to us directly if you have any follow-up questions and want to talk about particular arrangements or curiosities you have about how to comply with these final rules. It's been our pleasure to talk today about it. Thank you all.